Okay, so we are broadcasting so people can start joining us. So Dr. Braverman and Dr. Prakash, the way that we'll do this is I have a few intro slides. I'll introduce Dominga, and then before I start the presentations from you, I will have both of you say hello to everybody, and then we'll all turn off our cameras and watch the videos, and then me and both of you will come back on video for the Q&A. And I will read you some of the questions from the Q&A. And then we'll go for an hour. And then whatever questions we didn't reach, we will have them submit in our Help and Resource Center. And if you want to play around on the Whova app and answer some of them, you can totally do that too.
Okay.
All right. Awesome. We already have 12 people with us that are excited about this, I'm sure. We had a lot of people signed up. Very exciting.
Awesome. I'm kind of nervous about turning off any buttons, honestly.
Yeah, I know. If you want, I think I can do it from here, and then it'll prompt you when I ask you to turn back on your video, and maybe that would be the safest way.
You want me to? I can turn it off here if it's good to try it.
Yeah, why don't we just try it?
We might as well try it now.
Okay.
And for everybody joining us, just give us just a moment as we do some technology checks. We were having some problems.
Can you hear us?
Back, Alan.
We have to make sure we can hear you.
Yes, can you hear me?
Yes. Okay.
So it's all working. So I think we'll go ahead and get started. It is noon and people are joining us. So welcome everybody. My name is Katie Wright. I'm the director of the VEDS movement. And I also have Dominga No here with us today with the Marfan Foundation. She will be managing the chat box in Whova. So feel free to let us know where you're joining from and have some conversations in there during the presentation. Dominga will be there. We are very excited for this International E3 Summit, educating, empowering, and enriching our community. I believe this is the final day of the E3 Summit, and hopefully you've learned a lot from these presentations. These are brought to you by the Marfan Foundation and its divisions, the Loeys-Dietz Syndrome Foundation, and the VEDS movement, and our partners in Europe at the CERN. We are making history. I checked this morning, and we have 2,810 people registered from 72 countries across the world, which is truly incredible. I hope that you've been able to connect with some of these people in the Whova app, and hopefully these will turn into lifelong relationships for you. I know it's very special when we get to connect with people in this community. We are very grateful to our presenting sponsors, Brigham and Women's Hospital and American Communication Construction, for helping us bring this International E3 Summit to you. And we would like to let you know that this is a forum to provide an open discussion of issues related to genetic, aortic, and vascular conditions. Opinions stated in each of these talks are those of the speakers and not necessarily those of the Marfan Foundation or the CERN. So if you do have questions or need clarification about a difference in opinion between session speakers, please feel free to reach out to us at marfan.org/E3ask. That will get you to our Help and Resource Center. And just keep in mind, we are receiving a lot of questions right now during the International E3 Summit, but we will get back to you as soon as we can with your answer. And before we start the presentations and before I introduce you to our speakers today, I would encourage you to let us know how we did today by submitting the survey in the Whova app for this presentation by clicking that little rate button right there. That will let us know how you enjoyed this session, what you learned from it, and just be really great for us to know. We also have opened an E3 Summit survey at marfan.org/E3survey. And we hope that you also submit that survey to let us know how you liked the E3 Summit as a whole. And to show our appreciation, we will be selecting 3 submissions at random to win a $50 prepaid international debit card. Surveys submitted by 11 p.m. Eastern Time on September 16th will be eligible for the drawing. So we really hope that you let us know how you liked this and help guide us for future decisions about this. So I would like to take an opportunity to introduce you to both Dr. Siddharth Prakash and Dr. Alan Braverman, who prepared presentations and will be ready to answer your questions today. Dr. Braverman, since you're already off mute, I'll let you say hello to everybody first.
Hello, everybody. It's Alan Braverman in St. Louis, Missouri, and I'm an adult cardiologist at Washington University in St. Louis, and have been the director of the Marfan syndrome and aortopathy clinic here since our inception over 25 years ago. And I'm proud to partner with the Marfan Foundation and with Vassern and with all of you, and to work with Siddharth today. Thank you, Dominga and Katie, for this session, and thank you for everybody for your attendance. And I hope it'll be informative, and we'll try to do our very best to answer the questions you have and make this as informative a session as possible. Welcome.
Thank you so much, Dr. Braverman. And Dr. Prakash, would you like to say hello as well?
Hello, my name is Siddharth Prakash. I'm a professor of internal medicine and adult cardiologist in Houston, Texas. It's my distinct pleasure to participate in this forum with Dr. Braverman, and I'm very grateful to Josephine Grima and all the leadership, including Katie Wright, in this wonderful summit. We'll do our best to answer your questions.
Thank you both so much. We will be turning off our videos now to let you watch presentations provided by Dr. Braverman and Dr. Prakash. And we will come back after these presentations for a Q&A. So if at any time you have questions during the presentation and want your questions answered, we will do our best to get to as many as possible today. You can do that by submitting your question in the Q&A box in Whova. If you do raise your hand or put it in the chat box, I won't see it that way. So go ahead and make sure to put that in the Q&A. Thank you, and we will go ahead and move on to the presentations.
Hello, I'm Dr. Alan Braverman, director of the Marfan Syndrome and Aortopathy Center at Washington University in St. Louis School of Medicine. Today, Dr. Siddharth Prakash and I will share this lecture on Can I Do This? Your exercise questions answered. I'll review some Exercise 101, information about exercise and its physiology. And what do we know about exercise in the aorta, specifically aortic enlargement and dissection? What are the guidelines about competitive athletics? And most importantly, about recreational exercise for our community? Dr. Prakash will discuss exercise research, recreational activities, sports and exercise, safe and low risk, and end with practical considerations. And then we'll have your questions. First of all, warning. Exercise is known to cause health and happiness. It has benefits to the heart and skeleton. It can lower blood sugars. People can help lose weight with exercise, lower risk of breast and colon cancer, and it has important social and mental health benefits with less exercise, anxiety, and improved mood. People who exercise generally live longer than those who are sedentary. So how do we counsel individuals and give advice to those with heritable aortic conditions like Marfan, Loeys-Dietz, vascular Ehlers-Danlos syndrome, and non-syndromic heritable disorders regarding exercise, both for those who want to be athletes and, importantly, for our large community of recreational non-athletes? Do we really know what type of exercise is safe and how much exercise is safe? And do we always have the right answer? We typically err on the side of being safe. There really aren't any good outcomes data. In other words, the advice given is generally that based on consensus, judgment, and expert opinion. Not because we know that certain exercise is safer or more dangerous than the others, but based on what we know about the physiology of that exercise, we try to recommend things that should be low risk for our community. For some, physical activity concerns is more dominated by extracardiac or features away from the heart. It could involve risk of retinal detachment or lens dislocation problems, problems from the skeleton, such as the neck, hip, feet, or back, or it could involve the lungs or the thoracic cage. We worry and think about blood vessels for all these conditions, some more than others, depending upon the specific genetic condition, whereas others have problems from the heart muscle or concerns about valve disease or cardiac arrhythmias, and in some, long-term blood thinners or anticoagulation impacts recommendations about sports and exercise. Importantly, not everybody has the same risk, and therefore the recommendations have to be individualized. For some, even with a genetic condition, the aorta remains fairly normal in size at that time when we're seeing the individual, whereas others, the aorta is significantly enlarged, and recommendations are going to differ, as they are for those after aortic dissection surgery or when being managed with a chronic dissection of the descending or the rest of the aorta. We understand that the demands on the heart and blood vessels differ. So let's review those depending upon what types of exercise or physical activity that one's interested in. In general, exercise can be broken down into dynamic exercise, also called isotonic. And this is what we see when muscles move, like with walking or swimming or light jogging, where muscles move, blood vessels enlarge, and really leads to only a very modest change in blood pressure. And that differs from somebody doing static exercise, especially intense static exercise against a fixed load where muscles reach fatigue. So this is a condition, or isometrics, where muscles contract, but they don't move. And that associates with sometimes very marked increases in blood pressure. And that can affect stress and strain on the aorta and blood vessels. Exercise also differs whether it's competitive or recreational. Competitive athletics involves training to be the best one can, pushing oneself to the highest possibility in pursuit of excellence personally or achievement for the self or the team. And that's different than recreational athletics, which by definition, or for fun, or for fitness, can typically involve more light and moderate exercise. And this is what we really emphasize for our community in living long lives and protecting our bones, heart, and the rest of us. We can get a good idea about the hemodynamic or blood pressure and heart rate response to exercise depending upon the type of activity and the level of the intensity, and importantly, the conditioning of the individual. So some people who are in good shape have little change in their heart rate and blood pressure during certain activities, whereas others who are very sedentary and out of shape can have changes in their heart rate with more modest exercise. The metabolic equivalent of task, or the MET, is a simple physiologic measure to express how much energy or calories that are used during certain physical activity. Giving this lecture, sitting quietly at my desk, is very low activity, 1 MET. But with exercise, the MET equivalent increases depending upon the level of exercise. And that's an important number to think about because we can kind of predict the heart rate and, importantly, the blood pressure response depending upon certain circumstances. Blood pressure increases on average about 10 millimeters per MET of activity, with only little change in the diastolic. So the top number, the systolic blood pressure, typically goes up depending upon circumstance. And we know that the higher blood pressure leads to greater aortic wall stress. So in general, people with genetic aortic conditions, we recommend limiting activity and preventing extreme or maximal exertion, especially with straining. And there are lots of tables like this one, which can give a good example of where to kind of stay in these green or yellow zones for most activity, depending upon individual circumstances, with more leisurely recreational activity, and avoiding things that lead to a more elevated blood pressure and heart rate response during sustained or more intense activity. The American Heart Association and the American College of Cardiology has divided competitive athletics into classification of sports, trying to identify what are the ones with the highest static or isometric and the highest dynamic components, and what about the potential for bodily contact. So this involves competitive athletics. So you can imagine low levels of competition involving sports like golf, bowling, and yoga have low levels of impact on the blood pressure and heart rate response, whereas more dynamic sports with soccer and field hockey and more static sports or isometrics like weightlifting and rock climbing have different effects with increasing blood pressure response in these. And some have high levels of both, even though most sports have some level of both isometric and dynamic components, with the highest levels in endurance cycling and rowing. It's also to remember that impact and collision or risk of these impacts and the effects of these impacts differ depending if you're doing little league or elementary school, junior high, and of course it gets much higher as one goes into high school and college. So we generally favor these low impact sports in younger people and stay away from these in competition as one gets older. People with genetic aortic conditions or at risk for these wonder, can I cause an aortic dissection by my exercise? Will it affect the aortic growth over time? There is some information about this, but thankfully, these are pretty rare circumstances for aortic dissection in exercise. We know that bodybuilders and intense weight trainers that lift against loads, especially with straining, can have dramatic increases in blood pressure, even 300 millimeters of mercury during maximal weightlifting, especially during the Valsalva maneuver where you have to grunt or bear down to keep forcing to lift against the maximal load. And that can lead to surges in blood pressure, and that does place a significant, although transient, stress on the aorta. And these are sort of activities that we avoid in underlying genetic conditions. There are rare reports of acute aortic dissection related to intense physical activity in people who have risk for this, especially those with unexpected large aortas. There is information about remodeling of the aorta or enlargement of the aorta during exercise. But this generally comes from elite athletes that do sustained exercise for long periods of time. The aortic root is larger amongst elite athletes than those who don't exercise at all, slightly, and especially in endurance-trained athletes. This is an interesting study of 100 weightlifters, power lifters, bodybuilders, strength-trained athletes that are professionals that were not recognized to have any underlying condition associated with aortic disease. And they were followed over time. And the strength-trained athletes did have bigger aortas than those matched, same age, that weren't exercising at that level. And interestingly, in the green bars, you can see that those strength-trained athletes that exercise for the longest period of time, 4 years, versus these bluish bars at initiation of exercise, had larger aortas over time. Former NFL football players. So these are men in their 50s compared to similar non-football players in their 50s who are now 20 and 30 years after their training, especially linemen that did very intense weight training for years, had a larger proportion of bigger aortas, as did long endurance masters endurance athletes. So these were over 50 years old for 10 years or more of endurance athletics at high levels. Rowers and runners had more aortas that were enlarged than controls, both men and women. So there probably is something to long-term endurance athletics and aortic growth. So we think about that when we try to give advice about people's exercise levels when they have risk for aortopathy. Sudden death in athletics, which is something we worry about when giving advice for exercise, is very rare in athletes. You can see the numbers, 1 in 200,000, 1 in 750,000 female high school and college athletes have sudden death. And the vast majority are related to heart muscle disorders like hypertrophic cardiomyopathy or abnormal coronary arteries. Only a small proportion, 2%, of these rare deaths in athletics were related to aortic rupture. What do we know about the risk of aortic dissection in people with Marfan syndrome? Because Marfan syndrome is the longest known genetic aortic condition and easy to recognize relative to some of the others. In the past, we had larger information sets. Very little information about the risk of aortic dissection. predominantly for individuals who did not know they had the condition and continued to play. We didn't know their aortic size, and then high-profile recognition of aortic dissection and death was the diagnosis of Marfan syndrome. In a registry of sudden death in athletes, again, large numbers here of a rare condition, 2,500 in this registry. Only 1% were due to aortic dissection or rupture, but it usually was Marfan syndrome, undiagnosed or unsuspected. More males than females, with sports that are most commonly played being associated with this rare condition. We really don't have any good information about what the effect of continued intense exercise of the aorta in somebody who's known to have a genetic aortic condition, like these high-profile elite athletes that were discovered to have Marfan syndrome later in their playing career, so to speak, in college and beyond, and these two individuals, because generally when the condition is diagnosed, participation in competition is generally prohibited because of that concern for aortic risk. So we don't really have good information about what happens next if somebody did continue, because our recommendation is to curtail that activity at the highest level for most individuals. And the Heart Association and American Heart Association in college have recommended this approach for competitive sports in people with Marfan and related heritable aortic conditions, that if there's no history of aortic enlargement, dissection, branch vessel disease, or systemic features precluding competition, or early aggressive family history, that low dynamic and low static sports are reasonable, as long as there's no intense physical exertion or high level of bodily collision. So most of our recommendations really are for the vast majority of us in our community regarding non-competitive recreational exercise, which for most would be considered low risk and safe. And that's what the associations recommend. The Heart Association, AHA, European Society of Cardiology. A genetic aortic condition individual is recommended to avoid collision sports and strenuous activities involving lifting, pushing, and straining, and intense isometric activity, and to favor non-competitive dynamic exercise, walking, jogging, swimming, bicycling, tennis, at levels where one can communicate in a conversational voice. Finally, many individuals with genetic aortic conditions are on medications such as beta blockers to reduce the heart rate and lessen the force generated by the heart during contraction. And these do limit heart rate response during exercise, but they don't allow the person to continue to perform or to do intense strenuous exercise because it doesn't protect the aorta from surges in blood pressure. ARB drugs like losartan really don't have any significant effect on heart rate or allow one to do intense physical exertion. And for some individuals on blood thinners like warfarin, there is risk of bleeding related to trauma and falls, and one has to mitigate that risk during physical activity. People with aortic disease, especially after aortic dissection, can have significant mental health concerns, and some have post-traumatic stress. In this survey of lifestyle modification, mental health, and exercise practice from the IRAD, about a third of people had new onset depression and anxiety after surviving aortic dissection. And many were no longer exercising, and many were no longer sexually active because of concerns after aortic dissection. Importantly, those who exercised routinely had less depression and lower blood pressure. So there is a great hope and great importance of exercise in our community for lifelong health and well-being, with individual variation in specific exercise recommendations depending upon one's condition. Thank you for the opportunity to speak to you today. Dr. Prakash will finish the discussion as we remember to protect the tube of life and live a long and successful lifestyle. And we'll answer your questions after our talks. Thank you very much.
Hi.
Hi, everyone. My name is Siddharth Prakash. I'm a clinical cardiologist and geneticist at the University of Texas Health Science Center at Houston. And I'm talking today about exercise risk in patients with aneurysms and dissections. Some questions that my patients ask me about exercise in clinic are, I have an aortic aneurysm. How can I remain active and live a productive and healthy life? What exercises do you recommend for people who are at risk for aortic dissections? And after surgical repair of my aorta, what activity levels may be appropriate? To answer these questions, I will share some information that we use to assess our patients and some information that might help you prepare for living an active and healthy life. First, the overall question about what your personal risk to have a vascular dissection must take into account several factors. We know that all patients who have heritable thoracic aortic disease or another genetic mutation that may predispose you are at risk, but the risk is not proportionally distributed among all people. We know that there are risk factors like having high blood pressure, the type of genetic mutation that you have, which you may have been counseled about by your physician, whether or not you've had previous aortic surgery, and pregnancy can all increase a person's risk to have a dissection at particular times in your life. So these things must be accounted for when we make a plan for exercise. So how safe do we know that exercise is for patients who have aortic disease? Well, there have been several studies that showed that moderate exercise is valid for patients who've had abdominal aortic aneurysms and may even decrease their rate of expansion. We know that patients who have undergone cardiac rehabilitation exercises after thoracic aortic repair appear to do well and that this is safe in 3 different studies. And finally, more recently, in mice with Marfan syndrome gene mutations, we know that moderate exercise actually slows down the rate at which their aorta enlarges and may help to prevent dissections. Taken together, all of these studies show that exercise is safe and may actually be therapeutic for patients with aortic disease if done under appropriately controlled circumstances. On the flip side, we know that many dissection survivors had been engaged in vigorous physical activities immediately prior to dissection. The most prominent of these may be weightlifting or other types of isometric exercises, which we'll get into later. We know that the intensity, acuity, and dynamic component of exercise may differentiate what is beneficial from what is harmful and what may trigger dissections. Therefore, the type of exercise that you wish to engage in also affects your risk. And of course, uncontrolled high blood pressure is the #1 risk factor for aortic dissection. So it is really important to get that under control and be on preventative medical therapies before you start exercise. The reason for this is that the pounding of your pulse that you may feel during exercise actually reflects the distension of blood vessels. And this occurs not only in your wrist where you may feel your pulse, but also in the aorta. And this increased pressure puts stress on the aortic wall. If you already have an aneurysm or you have a thin aortic wall from genetic disease or high blood pressure, this further increases the risk for distension, enlargement of your aneurysm, or dissection. And again, we know that there are risk factors, some of which we can measure to give us a better indication of the risk. So what is the most important thing before exercise? You need to know and control your blood pressure. We recommend for patients with Marfan syndrome and related disorders that their resting blood pressure be less than 130 systolic over 80 diastolic. And this can change over time, as I mentioned. So it's important to keep track of your blood pressure and make sure it's treated if it is high. So the other thing to know is the status of your aortic disease. This requires lifelong follow-up, as most of you know, that all children and adults with heritable vascular diseases require lifelong surveillance. This can run anywhere from annual checkups with your primary care physician to regular blood pressure checks and medication adjustments, down to detailed imaging of blood vessels by a cardiologist. And this can be through computed tomography, magnetic resonance angiography, or echocardiography. From every 6 months to 3 years, depending upon the status of your particular disease and your location. So it's important to have regular individualized checkups for your aortic disease and know what it is before you embark on an exercise program. In terms of blood pressure, since it's the #1 risk factor, we spend a lot of time making sure our patients do not have high blood pressure. And it turns out that blood pressure we measure in the office reflects only about 2/3 of the actual load of blood pressure that people experience. We know that there are effects of being in the clinic called white coat effects, where the blood pressure may be elevated for people when they show up in our office, but normal at home. And on the flip side, we know that many people who show up with normal blood pressures in the clinic actually have high blood pressures at home. So we're missing or misdiagnosing a substantial amount of hypertension if we simply rely on office blood pressures. So this is where ambulatory blood pressure comes in. We know that your blood pressure over the course of 24 hours does not remain constant, but has normal variation, peaks and valleys that can influence your individual risk for dissection. This has to do with the time of day, how active you are, when you take your medications, and other disease-related factors that are very individual. So it's hard to predict just from a single blood pressure measurement. So in particular, when you go to sleep at night, your blood pressure should drop, but we know that in some people with vascular disease, including aneurysms, this doesn't happen, and the blood pressure may actually rise. We wouldn't detect this unless we were measuring this through the full 24 hours. So this shows an example of a 24-hour blood pressure measurement in one of our clinic patients. And what we're looking at here is on the long axis, the hours of the day from 12 p.m. on day 1 to 12 p.m. on day 2, reflecting 24 hours of blood pressure measurements. Each dot on the graph is the time in which blood pressure was taken. And on the vertical axis, you can see the blood pressure measurements. This patient has significant hypertension, as indicated by the red line, which is the systolic blood pressure, being above 140 for most of the day. But as you can see at night, the blood pressure drops to normal levels before rising again the next morning. Therefore, this is stage 1 hypertension with a blood pressure between 140 and 160 most of the time, with intact nocturnal dipping, that drop in blood pressure at night. In contrast, this patient has the opposite problem. You can see that during the day, from 9 a.m. to roughly 9 p.m., their blood pressures are largely within the normal range. But in that purple shaded area at night, their blood pressures rise quite dramatically and become quite hypertensive. This is called reverse dipping. So instead of dropping, as I mentioned, their blood pressure would abnormally rise at night. And this can reflect other kinds of pathology like sleep apnea that we often need to investigate and can control successfully with minimal interventions. And we know that when this type of blood pressure pattern happens, patients may be at risk for aortic dissection at night. Here's a case in which a patient has normal resting blood pressure, but in times when they're active, as indicated by the gray squiggly lines on the horizontal part of the graph, their blood pressure surges with exercise. So this is exertional high blood pressure with otherwise normal features. And you can see that in many patients with aortic disease, their blood pressure may be normal at rest, but elevated at exercise. And in those patients, we often do additional tests to show that exercise may be safe for them before we permit them to do a full exercise program. So this shows the influence of dipping patterns that drop in blood pressure at night on patients with aortic disease. In this study, 76 patients who had previous aortic dissections were examined by our ambulatory blood pressure monitoring for 24 hours. And on the right, you can see that those that did not have normal dipping at night were more likely to have aortic dissections overnight than those that dipped normally at night and had dissections during the day. So the dipping pattern seems to influence the timing at which the aorta may be at greatest risk, based on the fact that the blood pressure would be highest at night at those individuals who did not dip normally. And finally, this shows white coat hypertension. And when the blood pressure cuff is placed in clinic, the blood pressure is high, but as soon as the patient goes home, the blood pressure is normal. Patients like this can be overtreated because we assume that they have high blood pressure when they don't. This white coat hypertension can cause problems by side effects of elevated doses of medication that are not actually needed. So we wouldn't know this if we just relied on an office blood pressure. So if we diagnose hypertension, regardless of the method, we do recommend that it's treated with two main types of medications, beta blockers on the left and angiotensin receptor blockers like losartan on the right. An example of a beta blocker would be metoprolol. And the mechanisms of action are different. The metoprolol slows the heart rate and decreases the sympathetic drive of the nervous system. This is appropriate in most patients because it actually protects the root of the aorta and ascending the best, and that is what is most often affected in thoracic aortic disease. Whereas angiotensin receptor blockers function by a different mechanism, lowering the blood pressure throughout the body and also reducing the amount of fluid retention. It's important to know that most people who had dissections with or without exercise were actually not taking adequate doses of their blood pressure medication. So once again, visiting with your doctor and working with them to establish the proper dose is essential before you start exercise. We also know that the risk of exercise is associated with whether there's dynamic or isometric exercise, because the pattern of rise of the blood pressure is quite different. On the left, I'm showing you a dynamic or aerobic exercise in which someone is running. And during that time, you can generally see a gentle rise in the systolic blood pressure with virtually no change in the diastolic pressure that levels off and eventually decreases as soon as you stop. However, with isometric exercises, we know that blood pressure can increase quite dramatically. This shows the classic example of weightlifting. And in actual fact, it's not a smooth rise, but it's more like a squiggle, where with each repetition, blood pressure will peak relatively quickly and drop off just as quickly when the effort is relaxed. So this kind of rapid alteration in blood pressure is actually even more deleterious because it causes an increased rate of strain on those blood vessels that we were talking about. And not to mention the fact that the absolute value of the blood pressure increases is quite a bit greater than with aerobic exercise. So in summary, systolic blood pressure increases more gradually and in proportion to the percentage of body weight lifted in aerobic exercises than in isometric exercises. In isometric exercises, the increases in blood pressure are sudden and short-lived. They're very difficult to measure because of the fact that you're doing a Valsalva and holding your breath during isometric exercise. There's a lot of variability depending on the technique and the training that you have. And there's limited opportunity to adjust the intensity of exercises before you reach that critical threshold of very high blood pressure that we would be concerned about as a dissection risk. Whereas aerobic exercises have a more predictable and gradual increase that can be more readily measured during exercise, as I will show you. And this provides us an opportunity to adjust the intensity of exercise to reduce your risk of dissection. This is data from our clinic showing the changes in systolic on top and diastolic on bottom blood pressure for a variety of different exercises that are written across the bottom. Leg raises, hand grips, bicycles, bicep curls, and a wall sit, in which you pin your back against the wall with legs roughly parallel. As you notice, the leg raise and the wall sit have the most dramatic changes in systolic and diastolic blood pressure. And this is because they're isometric exercises where you're not moving, but maintaining contraction. Whereas bicycle has a relatively minimal change in diastolic blood pressure and a relatively smaller change in systolic blood pressure. So this illustrates again the difference between the types of exercise, and we think that it makes it more reasonable for us to consider dynamic or aerobic exercises in our patients as a first method when we're starting an exercise program. This just shows a graph from the American Time Use Survey that shows the relative amount of effort that's required for both static or isometric and dynamic components of exercise. And most of the time when we're talking about moderate exercise, we're talking about the blue squares towards the lower, the bottom, and the left side of the graph. And that means things with relatively small static or isometric components and less than vigorous dynamic or aerobic components. So walking, hiking, and other types of non-contact sports. And the other important long-term effect of aerobic but not isometric exercises in data from our group is that with training, the exertional blood pressure can actually drop in aerobic exercise, but not in isometric exercise. This shows the graph of patients who claimed different levels of moderate activity per week. And you can see that on the right, for those who had more moderate activity each week, up to 400 minutes, their maximum blood pressure during bicycling was significantly lower than those who had minimal moderate activity per week, whereas the numbers are not particularly consistent for the wall sit and isometric exercise. Therefore, training is also possible to reduce your risk if you start with a relatively low amount per week and gradually increase your capacity. We also know that blood pressure peaks during exercise are associated with risk. This graph shows treadmill exercise, a common form of cardiovascular risk assessment. If your blood pressure remained less than 150, your risk of dying from cardiovascular disease over the subsequent 20 years is almost twice as low as if your blood pressure increased to more than 160 millimeters. And this is during a regular, relatively moderate stage 2 treadmill exercise, which would not be anything close to maximum or vigorous activity. So there is significant predictive value in becoming hypertensive during exercise, and we can do something about it, as I'll show you. We put our patients on the treadmill, and this is an example of two profiles that we often see. So patient 1 has normal resting blood pressure and heart rate, but as soon as they get on the treadmill, you can see that the blood pressure on the right there in the red box dramatically increases up to 225 millimeters of mercury, almost twice the resting blood pressure, and remains elevated well into recovery after exercise. Whereas patient 2 on the bottom has a relatively higher baseline blood pressure with baseline stage 2 hypertension that peaks early, plateaus, and actually decreases with exercise. So compared to patient 1, patient 2 would actually be at lower risk, but you wouldn't know that from their baseline blood pressures. So therefore, exercise blood pressure response is not predictable from baseline blood pressure, which is important to know when we're trying to risk stratify our patients. We also noticed that patients who achieve hypertension during exercise and remain hypertensive and tachycardic after exercise finishes are at longer risk. This shows two graphs, one with the heart rate and one with the blood pressure in black and blue and black respectively. And you can see that after exercise ceases at around 20 minutes, blood pressure and heart rate usually drop synchronously. But in some patients, they remain elevated out to 30 minutes. And so we often check for this effect in our patients who exercise, because we know that they're at higher risk if they maintain their hypertension for a longer period. We also check something called vascular stiffness using a type of blood pressure cuff called a sphygmocore. This is something that we can do in clinic because it also shows that a predictive value for determining which patients may be at risk in the future for high blood pressure or aortic events. And this device works by extrapolating the aortic or central blood pressure that the blood vessels actually experience from the peripheral waveform by measuring in different wave reflections from the periphery to the center. It's called arterial waveform analysis, and it will allow us to risk stratify our patients more than just the regular cuff blood pressure does alone. So this shows an example of two patients in our own clinic who had different central aortic pressure profiles. In patient 1, we have a 53-year-old man with vascular EDS who had had no previous dissections. You can see that his arterial pressure waveform is relatively normal. It shows two peaks, an early shoulder of the forward wave from the heart, and then a higher peak of the reflected wave. He has a normal profile, and with relatively normal central aortic pressure, we would call this a normal aortic stiffness study. Whereas this 26-year-old woman with multiple previous dissections actually shows the opposite problem. She has what's called significant augmentation, a peak causing excessive force in the central aorta, more than what would be predicted for her age and sex. And this reflects increased stiffness in her vessels, which is a marker for future aortic events. Now, we hope to, by phenotyping more of these patients, even before they have aortic dissections, we can predict which patients may be at risk and then treat them with medications to actually counteract this stiffness effect, measuring the effect by serial approaches. So in summary, we are trying to
control all three components of hypertension in order to reduce a person's aortic disease risk. There is the blood pressure we measure in the office, the ambulatory blood pressure that occurs during natural 24-hour variations, and exertional blood pressure, as well as vascular stiffness. The three of these together account for a person's total risk due to high blood pressure. And we have to measure and treat all three of these components in order to improve outcomes in high-risk patients with vascular disease. So what do we tell our patients? We tell them that they can lift whatever weight they can comfortably lift without having to bear down. We don't recommend isometric exercises as a starting point, and we want to try to titrate their risk based on their blood pressure and response to aerobic exercise. We do recommend regular aerobic exercise because, as I showed you, training can reduce the blood pressure response and therefore decrease your risk. We also think that training can reverse some of the aortic stiffness and vascular stiffness that we can measure on the sphygmocore. And what about if patients want to engage in more intensive exercise regimens, like a marathon, or want to do training for an athletic event? How do we manage them? Well, in our clinic, we do a multi-step protocol, which takes into account history and physical and genetic evaluation. That includes the type of mutation they have, their family history of aortic dissection, any contraindications they might have to exercise outside of their heart or blood vessels, like skeletal problems. We do an ECG, we do the sphygmocore waveform analysis to assess their vascular stiffness and for evidence of underlying cardiac disease. We measure baseline hypertension. And we will do a battery of tests, of course, that include imaging to assess their aortic disease. If they wish to engage in vigorous exercise, we put them on the treadmill and measure their aerobic response to exercise, as I showed you, to look for exercise-induced hypertension and to measure activity thresholds above which their blood pressure may increase to dangerous levels. And we also analyze their 24-hour pattern to assess for the reasonable expectations about timing of exercise and whether their medications need to be adjusted. This leads to an exercise prescription that includes targeted antihypertensive therapies and a risk reduction strategy of slowly graded exercise over time. We can then reassess this at intervals as they progress in their training to adjust the targets as we need to keep our patients safe and active. Thank you very much.
Thank you so much, Dr. Prakash and Dr. Braverman, for those wonderful presentations. We will be answering questions now, so I'm going to get Dr. Braverman and Dr. Prakash back on video here and unmuted. So why don't you, Dr. Braverman, I know we were having problems earlier. Can we still hear you? Do you want to test it real quick?
I'm here.
Perfect, great. And I'm sure, Dr. Prakash, we had no issues earlier, so I'm sure I can hear you as well.
Right here.
Awesome. Okay, so we have a lot of awesome questions in this Q&A box right now, and we're going to hit as many as we can. I know some of them are very similar, and some of them were also answered during the presentation, but we might just revisit those areas again. So for our first question, this has received the most upvotes. How do you figure out with a connective tissue disorder how much pain you should be pushing through when exercising? And my guess is that this pain is probably, they're talking about like muscle or joint pain that might be chronic. So I don't know who wants to go first. How do we want to do this?
Alan, you want to take this?
You know, I would, that's an important question because it does impact the quality and the comfort when one is exercising. And every individual does have a difference. Some have pain in the foot or ankle, some could have knee pain, hip pain, or back pain, all dependent upon the underlying condition. Joint laxity, hypermobile patients can have significant difficulty. So if someone's facing that issue, I often work with a physical therapist first to find out what the structural issues are that can make the exercise easier, safer, and more comfortable, rather than, because it could be that the individual's going to have further injury to that joint or structure because of the ongoing symptom. The symptom's an important one, and so we recognize that and say, how do you mitigate that by doing something different, changing a technique, or changing an exercise altogether. Some people, when they walk, they have discomfort. If they use elliptical or bicycle, they feel fine and get great aerobic capacity from that. So I think you really have to go take a deeper dive to what exactly hurts and why, and then how to make that better. In some, pushing through is perfectly appropriate, but I think we want to try to understand why and try to limit that to make it more fun and safe.
Great. So Dr. Prakash, do you have anything to add, or are we good for the next question?
I would simply add that if you are experiencing pain, make sure you check it out before you start the exercise program you intend, because as Alan mentioned, it can reflect a deeper concern that can actually make things worse and not better.
And our next question, you both touched on this during your presentations. What exercises and activities should people with Marfan syndrome and connective tissue disorders be doing to maintain muscular and joint health?
Well, I can take this one. We both mentioned in our presentations, we think that aerobic exercise is a good starting point. That doesn't necessarily mean that all patients will be strictly confined to aerobic exercise. It's, again, a very individualized decision-making process. But in general, we know that the health effects and the safety of aerobic exercises are more certain at this point than for isometric type of exercises. And of course, depending on the other conditions that the individual is dealing with, skeletal problems, mobility issues, they can be tailored in order to make things more feasible and comfortable for people.
Great. Dr. Braverman, do you want to add anything, or is that sufficient?
I think that's great advice. I love for everyone to exercise. And again, I really ask, what do you like to do? What's your interest? What's your goal? And really try to start like that. And it's much better than to try to make a list of things that one shouldn't do. Really, let's think one of the things that you like to do, that you want to do. What are you worried about that maybe you're concerned you're not doing because you're worried about it? And many times that's perfectly safe. So we just have that conversation and then move forward.
Great. And I'm going to some of these are very similar. So I want to make sure that we get as diverse questions as possible. So I think I'm going to go for Dr. Prakash for this one, because you had a lot of data on blood pressure and individualized approaches in your presentation. And then Dr. Braverman, you can add to this. Why do we not look at the aorta size and the Z-score and set activity levels based upon those results? Is everybody under the same guidelines regardless of aorta size and Z-score? And I think you addressed that during your presentation, but I'd like to get that answer again.
Right. So we routinely review all of these things with our patients before we consider what type of exercises may be appropriate for them. Clearly, there are differences depending upon the size of the aorta. And we certainly don't consider that patients with very large aneurysms are in the same category as those with mildly dilated aortas. Those are very specific to individual patients and their stories. And so the first recommendation I would have is to discuss the current state of your aorta with your doctor, because it does change and you need to be aware of how it's changing. If it is changing rapidly, that is a separate concern, and we would not recommend that anyone engage in a new exercise during that time. So stability and the current status are the most important things before you even contemplate starting exercise. And in that case, if there is enlargement, we would definitely, as Alan mentioned, err on the side of caution in terms of recommending light versus moderate or strenuous activities, and again, favoring aerobic type of exercises that are less likely to strain that aorta.
And Dr. Braverman, do you want to add anything to that?
I think the question is very intuitive, and is one of the most difficult things that I think all of us wrestle with. When somebody who's highly athletic and gifted competitor is found to have a condition for the first time, even though that person has lived an entire life of competition and activity at the highest level and has suffered really no consequence, and then is found to have a modestly dilated aorta with a new condition with a label of a genetic aortic syndrome. And as Prakash very nicely summarized, and as I can say, we don't really have any idea what happens next if that person were to continue. We just don't know, and that's the challenge. It's likely that the person would be fine when the aorta is very normal looking or minimally enlarged. And we really do think about that differently than somebody whose aorta is getting towards a threshold for surgery within the next months or a year. And but since we don't have that information, and one day we might, I do know that lots of people love to do things that make me nervous and would make me have difficulty sleeping at night when they told me what they're doing. And they do it. They love to do it. And it's just like having kids. You hope your kids are going to make choices, and everyone's going to make the choice that they're comfortable with. I do like the idea of putting people on a treadmill and seeing what happens to you when you're doing those things. So at least when I know they're doing those things, I can at least counsel that at least your blood pressure is good, or it's really not as good as we think, and maybe we ought to think about the way we're doing that. So I think individualization is very important. There are experts around the world that have very different opinions about what people can do. And the fairest thing to say is we don't really have good information. So I think laboratories like and investigators like Prakash identified, and others that are interested in sports cardiology and genetic conditions. And I think that's the way we're going to go in the future. So I do think there are going to be individual recommendations based on specific conditions, genetics, and physiology in response. But for now, I do feel better to be a little bit more restrictive on higher levels of activity in people who do carry some risk. And that's a difficult choice.
Thank you. And what about the psychosocial risk to kids starting a sport and then developing an identity around that sport that someday they'll have to quit? Do you both encounter that a lot, or what do you advise parents?
Yeah, I do. I mean, that's a super important point, and one that's very practical and real. So usually sports like t-ball and baseball at the lowest levels, you don't really carry that risk because the aorta is generally small. So again, there are individual differences in that and risk depending upon which condition. But for the athlete that's done that her whole life and now is at a much higher level of competition, it changes everything. So I think you're absolutely right. When one has the information early on in life, then you can help make discussion about, doing different things, whether it be computer science and drama and band and music and, all sorts of things, managing a team as opposed to being the person that is the captain of the team or her team. So I think it is easy, it's never easy. It's a little less difficult, I think, when you have time to make those changes. But I think that's something we all face and is just part of the importance of discussing this.
Great. And Dr. Prakash, did you want to add anything to that?
I would just add, as Alan mentioned, it's extremely important to do research. And one of the benefits that we found is people are motivated to do this research because they want answers, a large part because it is such a personal issue for so many people. And I think that's how we're going to move this forward, so we can actually give them informed and reasonable guidelines that do not feel as restrictive for everyone if they don't need to be.
Thank you. And we are coming up on time, but we've got a lot of questions, and I know it's Saturday. Are both of you available to stay maybe an extra 5 or 10 minutes to answer some more of these? I know we probably won't get to all of them, but if we could get to a couple more, I think that'd be helpful for people.
Absolutely.
Great. Okay. So do you know of any workout videos or programs made specifically for people with Marfan syndrome and or aortic aneurysms and dissections?
I don't know of any specific ones that, but I think that's a great project. I think that there'd be a lot of interest in that sort of research and production. So Katie, I think that's the next step.
Yes, let's plan on doing that. That's a great idea.
It sounds like a lot of fun. So we'll get working on that eventually when we can. I think that would be a great thing to have for people. So let's talk about golf for a minute. I know that is on the exercise chart down at the bottom left-hand corner where it's nice and safe. This person would like to know, is golf okay with a dissection? While it seems like a very relaxed sport, I wonder if the act of swinging and striking the ball raises blood pressure like a vagal maneuver. They're also not sure if they want the answer because they have a dissection and they enjoy playing golf very much.
I would say enjoy all the golf you can play. Take a cart or pull a cart probably, and use common sense in the really heat and things like that. Let your body be your guide. Don't sweat those 2-footers because that can raise your blood pressure. But otherwise, I'm teasing about that. But really, I think that's a great sport. It's most moderate levels of exercise with chronic aortic dissection. In patients with dissection is as you heard earlier, most of the time cardiac rehab is well tolerated. We can monitor blood pressure. We're really interested in doing cardiac rehab after the healing phase of aortic dissection. Usually not at the first 4 weeks like we would other cardiac surgeries and we usually wait about 3 months, kind of give it a little bit more time for blood pressure control. But I think it's very reassuring to see what moderate exercise, walking on a treadmill, riding a bicycle, things like that, how well that's tolerated, how emotionally and physically uplifting it is. And then you can continue that sort of exercise lifelong.
Dr. Prakash, I saw you smiling too at the question, so I'm going to give you.
Sure. Well, we actually have a fundraiser golf tournament every year where aortic dissection survivors participate and their families. And so I think, we have plenty of evidence that it is therapeutic for people with all types of aortic disease.
Yeah.
So hopefully if you ask that question, you feel much better and are grateful that you actually got the answer and asked the question. So how about, you talked a little bit, Dr. Braverman, just a minute ago about being mindful of the heat when you're exercising. Could you go into if there's a higher risk with heat, extreme temperatures, higher altitudes somebody's asking about, do those things impact your blood pressure while you're exercising? And I'm going to go Dr. Braverman first and then Dr. Prakash.
Well, there are certainly differences in the response of heart rate and blood pressure to exercise in different conditions. If you live at a higher altitude in Denver as opposed to at sea level, automatically you're acclimated and you're sort of used to that. So changing altitude is probably the biggest thing. But if you go from low level to 10,000 feet or more, there'll be a difference in oxygen saturation at that. So blood pressure will go up a little bit, heart rate will go up a little bit. So you're already starting at a kind of a higher load or kind of effort. And so any sort of activity for anyone, even, when you're perfectly healthy or when you're perfectly healthy and have an underlying heart condition of any kind, there are some precautions when going suddenly to a high altitude and doing activities. So that's very important to discuss with your provider before you go say, I'm going to go hike in the Rocky Mountains or something like that, just in general. The heat is really more dependent upon just the exhaustion factor if you're out there for long periods of time. So if you're golfing for 4 or 5 hours in 100-degree high humidity in Houston or somewhere like that, it's going to be different than doing that in 70-degree weather, in the spring or something like that. Exercise in really cold weather is something to think about. So wrapping up warm, keeping your hands warm, your face warm, wearing something over your face if it's in the freezing cold. We usually say you're kind of limiting more moderate or severe exercise. Do light things if it's going to be very cold where you can see your breath, things like that. Shoveling snow is kind of one that in people who have underlying cardiovascular conditions, it can associate with higher blood pressures and just more demand. The blood vessels kind of constrict in the periphery, so there's just a little bit more pressure on the inside. But in general, things in moderate temperatures should be fine. When there are extremes, best to do things much more modestly.
And Dr. Prakash, did you want to add anything to that?
Sure. So we frequently during the summer months encounter people with dehydration. This is common in people throughout the age and disease spectrum, but it can hit people with heritable vascular diseases particularly hard for 2 reasons. Many of them have autonomic dysfunction, so they can tend to develop low blood pressures in any case, and it's worse with dehydration. And as Alan mentioned, many of our patients are taking medications that lower blood pressure anyway. So they have to be very cautious and stay well hydrated when they're outdoors, even for short times, but especially if you're going to be out for more than an hour, that is a major concern.
Thank you. Do you have a recommended maximum heart rate to not exceed during cardio exercise? I guess Dr. Prakash first. We'll just trade off.
Sure. So we often use heart rate as a marker for exertional level because it's easy for patients to check. They're not always going to check their blood pressure or other measures. And in order to do that, like we said, we usually put people on a treadmill. We measure their blood pressure at various heart rates. And if we see a surge, we can define a reasonable cutoff. It's just an estimate, but it sometimes gives people more confidence to engage in low to moderate activity. By no means is that a line in the sand. There are lots of variations that can explain why it would be different for different exercises. But I agree, it's very difficult to say in general, do not exceed this heart rate. It depends on fitness, depends on the type of exercise. There are a million different reasons why it would be different for different people.
Dr. Braverman, did you want to add to that?
No, I agree completely. And I do think it's important not to give a number and say, don't exceed that, because that's very limiting. As you heard earlier, that with more training, the heart rate response to exercise goes down. So somebody who's just beginning exercise will be frustrated often because the heart rate goes up so quickly and it just stops him or her in her tracks. So they're not able to do the things they want to do. I'm more concerned about a blood pressure surge than a heart rate surge during exercise. But in general, keeping things in more of a moderate level, more perceived activity level. So instead of doing things at a 10, doing things at a 5, 6, or 7 are just easier to do and kind of easier to think about. And if somebody does have a really rapid heart rate response to activity, kind of think about that and think about what can we train? Is there something about the training we can do that might change that? And it is highly variable depending upon where the resting heart rate is, what dose of beta blocker she's on or he's on. And so there are a lot of things to think about, but try not to just worry about one number to stay beneath.
Thank you. And I'm going to pick a couple more questions and then we'll end the Q&A. But if your question is not answered today, please feel free to submit it to our Help and Resource Center. We will do our best to get your question answered as soon as we can. For VEDS and probably for other connective tissue disorders as well, it seems that isometric exercises are bad. Are planks and squats as dangerous as deadlifting or like really heavy weightlifting? Dr. Prakash?
Sure. So we actually tested planks and squats along with wall sits and other forms of body weight only exercises. And we did find that that there is a significant difference between that and weight-bearing exercises like deadlifts. I think that overall the blood pressure rise is still much more significant than aerobic exercise, but I would say that if people wish to engage in any type of isometric activity, using your body weight would be preferable, clearly, to lifting heavy weights. And I would always caution against doing that, particularly if you have no experience in weightlifting and wanted to start a program. And for those people who do, to try to use the lowest weight possible that does not cause fatiguing, because we know that that also raises blood pressure.
And Dr. Braverman, did you want to add to that?
I think isometric exercise is very important for maintaining muscle tone. And so just using light weights, and for everybody that's a different amount, but so light weights with repetitions, we stop way short of muscle fatigue. It should be low risk for almost everyone.
And could you briefly define what muscle fatigue is for somebody who's not familiar with that terminology? How do you know if your muscles are fatigued?
So I think about it as when you really can't do much more without grunting or bearing down. So even using a hand gripper, or you might be sitting on the couch doing this, just to strengthen your muscles in your hand and your arm. Once you can't do it anymore and you're grunting and bearing down to try to just do one more, just like if you had a trainer and they said, push, 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 keep push, 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 push. So once you start doing that and you can't do this freely with whatever the weight would be, that's muscle fatigue. So if you can do 5 more very easily, then you're well short. If you're really bearing down, you're reaching muscle fatigue, so you can't do it anymore. That's when the blood pressure really surges for most individuals. Once you've reached that maximal contraction, you have to bear down and do the Valsalva maneuver and grunt. to push that a little further. Whatever the weight would be, whether it be a 10-pounder where you've done it for the 100th time, or whether you've done a 30-pounder for the 5th time, once you reach that muscle fatigue, you really want to stay way short of that.
Okay. And I have one last question today. What kind of exercises do you recommend for individuals with Marfan syndrome, BES, Loeys-Dietz related conditions who do want to increase their core strength, which we know is important to have? Are there certain exercises that are safe for that? Dr. Prakash, you can go.
Sure. So we've looked at a variety of isometric exercises, and something simple like a straight leg raise, when the person is lying on the floor and you lift your leg one at a time 6 inches off and hold it, seems to be relatively moderate in terms of the blood pressure effect. And yet it still can strengthen the core quite substantially if you can repeat that several times. Again, before significant fatigue sets in, we usually have them hold it for 30 seconds to a minute, depending on their fitness level. But patients do report that they feel strengthening from that, and we've been able to measure the blood pressure during those maneuvers more easily than other methods, and it seems to be moderate.
Great. And Dr. Braverman, did you want to add anything to that?
You know, sort of low-level yoga, low-level Pilates, moderate things like that, I think are really good for core exercise. And I think that's where videos and chat rooms and support groups like the organizations that you're all part of are going to be very important. To say, what have you done? What have you learned? What do you like to do? And share that information, and then it goes viral.
Thank you both so much for your expertise today, and thank you everybody for submitting your questions in the Huva app. Let's see here, we've got a couple slides for you before we end today. So if your question was not answered, please submit them to marfan.org/E3ask, and that will get you into our Help and Resource Center. Again, keep in mind we're receiving a lot of questions right now, but we know that everybody's questions are important, and we will do our best to get back to you as soon as we can. We hope that you complete the session survey and the E3 Summit survey that we mentioned earlier. And this is the last day of the E3 Summit, but the Huva app is still available, and we hope that you continue to connect with people in there, visit the exhibitors, and just connect with community around the world. If you'd like to share your experience on social media with this E3 Summit, we encourage you to use our hashtag E3Summit20, which will help us keep track of what you're saying online and how you felt about this. If you'd like to help us make more programming possible, you can do so at marfan.org/donate. We know that these programs are very important to a lot of people, and we very much appreciate your support. We hope that you join us next week, starting September 19th, going through the 26th for Aortic Disease Awareness Week, which is powered by the Marfan Foundation, and hope to see you raise your hands to raise awareness for the risk factors of aortic disease, which we know include all of our conditions together. And we really hope to see you participate. You can learn more at marfan.org on our social media, and I believe there is information in the Summit app as well. Dr. Braverman and Dr. Prakash, thank you so much for your time today and for staying a little extra for some of those questions. And I will give you an opportunity to say parting words to everybody if you have any final thoughts. So Dr. Braverman, do you have any parting thoughts for everybody?
Thank everyone for participating in this entire symposium for the last several weeks, and it's a pleasure to help in any way. So always available, reach out for questions, and if we can answer them, be happy to do so. And my best wishes to all of you.
Thank you so much, Dr. Braverman. I know our community really appreciates you. Dr. Prakash?
I would also like to thank everyone for sending in great questions and for participating, and I hope that you all go out and stay active and be healthy and enjoy life. Thank you very much.
Thank you both so much, and thank you everybody for joining us. We hope to see you in the Huva app and see you again soon. Have a great day, evening, morning, whatever it is, where you are.
Thanks, Katie.
Thank you, Katie.